Hello, my name's Sylvester McCoy. I'm an actor. I suffer from arthritis in my ankles. I call my arthritis in my ankles comedy war wounds, really, because my acting career was very physical. I was tumbling, falling. I'd fall downstairs just for a laugh. And I'd fall out of windows, again for a laugh. Not realising that years later I would suffer for it because I was really, really punishing my joints. And the pain came around when I got to about 50, and then it became almost impossible to carry on doing any physical work. So I had to get it fixed.
As you can see, ankle arthritis is a disabling condition. Most cases occur after trauma, such as multiple severe sprains or fractures of the ankle. This leads to progressive wear and tear of the shock-absorbing cartilage, and over years, the development of osteoarthritis. Ankle arthritis can be caused by other diseases, such as rheumatism or gout, but the end result is the same. The cartilage becomes worn away, the bones rub together, causing pain, stiffness, and it can have a major impact on the quality of your life.
I had to stop walking socially completely.
I was hardly able to walk at all. I mean, it was agony just getting across the bedroom to go to the lavatory.
I couldn't even stand very long for washing up or cooking.
Being up and down the stairs, not being able to drive a car.
Every year, up to 20,000 patients are referred by their GP to foot and ankle orthopaedic specialists to discuss surgery for their ankle arthritis. But only 3,000 of those ever come to surgery. Before surgery is considered, there are many non-surgical treatments that should be tried, such as using painkillers, changing your activity levels, weight loss, and physiotherapy. Supportive ankle braces can also be very helpful. If all these treatments have been tried and you remain in pain, then surgery may be considered. The two main surgical treatments available through the NHS are ankle arthrodesis and ankle replacement. Ankle arthrodesis involves removing the arthritic joint surfaces. The two bones are then held together with metal screws or plates to stop any movement, and over time the two bones fuse together to become one. This can be a keyhole procedure or open surgery depending on your circumstances. In total ankle replacement, the arthritic joint surfaces are removed and resurfaced with metal components. A plastic insert is then placed between the metal surfaces to allow motion. After both types of surgery, you are likely to need a plaster or a boot for up to 3 months and may be advised not to weight bear for the first few weeks. This will mean crutches or a frame to get about. Every patient is different, and your surgeon will discuss the most appropriate post-operative plan for you.
Now, it's quite difficult for you, the patient, to be able to decide between these two treatments. And there's never been a randomized clinical study to answer the question, which is better, an ankle replacement or an ankle fusion? Between 2015 to 2019, we ran a large multi-center randomized controlled trial of ankle replacement against ankle fusion. This is known as the Tarva study. The study was funded by a large £2 million grant from the NIHR, the National Institute for Healthcare and Clinical Research. We're delighted to be able to present to you the initial one-year findings, which have now been published. The Tarva study took place at 17 NHS trusts across the United Kingdom. 303 patients between the ages of 50 to 85 were randomly assigned to either ankle replacement or ankle fusion. So, what did we find? Well, overall, we did not show superiority of either treatment in terms of the change in our chosen clinical score at 52 weeks following surgery. However, when we considered the type of total ankle replacement, we found that the implant most commonly used in the NHS, a fixed bearing 2-component implant, had better outcomes at 1 year than ankle fusion, but must stress that this was a post hoc analysis.
In the study, we found that 43% of patients had evidence of wear and tear in the adjacent joints before their surgery. This is a finding never reported before. A subgroup analysis found that the presence of osteoarthritis in adjacent joints increased the effects noted between groups, favouring ankle replacement. We did not find a difference between ankle replacement and ankle fusion in the risks of experiencing any adverse events.
However, there were differences in the types of adverse events. There were more wound healing complications and nerve injuries in the ankle replacement arm, but more thromboembolic events in the ankle fusion arm. 12% of the ankle fusion group did not have bony union, on review of their plain radiographs at 52 weeks, but not all had symptoms. We report that the symptomatic non-union rate for ankle fusion is 7%.
Our data is essential to help patients and their surgeons make important decisions on the right surgery for them.
And we now intend to follow these patients for up to 10 years, where our findings are likely to become even more important. But most importantly is, what do our patients say?
I can certainly cycle happily, swim happily. I was doing 20-mile walks quite happily.
I can do my own shopping, which it was getting that because of the weight, carrying shopping, I couldn't do it. There's very little that I can't do now.
I'm back doing my 20-mile walks a week, and I've absolutely no problem.
I'm walking very well and without a limp, with total flexibility, and now's the time to see whether, like all retired people, I can take this up as another hobby on top of the gardening and everything else.
Half the patients you've just seen have had an ankle arthrodesis and the other a replacement. I certainly can't tell the difference. Can you? After both, you can still have an almost normal walking pattern and even manage stairs. But the Tarva trial has shown us the importance of having healthy adjacent joints to achieve the best outcomes.
Research allows doctors to improve treatments and the care that they can deliver for you in the future. And for your future, my future, and the future's future.